my topic is temperature management in ICU, and so in ICU, in terms of temperature management, we have both. We can have hyperthermia and hypothermia. So then, how to approach to a fever patient in ICU? As you know, that fever is the most common symptoms in any of the hospitalized patient in ICU, and and above them, hospital-acquired pneumonia is the most common hospital-acquired infection. The introduction of new technologies to diagnose the fever is in the modern times. We have many modalities, and early initiation of antimicrobial therapy with active against causative pathogen and pathogens is one of the most important part of the effective management of life-threatening infections, causes sepsis and septic shock. The recent expansion of multi-drug resistant and pan-drug resistant pathogens poses a significant challenge in the treatment of infection. And a systemic review of 9 observational studies in patients, it showed that between 26 to 88% of the population having fever of non-neurological condition in ICU. In addition to that, fever has also been shown to be independently associated with mortality for the patient getting admitted in ICU. Pathophysiology, core temperature typically exhibit some variation with a nadir of 36.2 degrees centigrade in the morning and peak at around 37.7 degrees centigrade at the afternoon. Temperature can elevate more than 39 degrees centigrade in febrile response to infection or other stress. Interaction of exogenous pyrogens or endogenous pyrogens like IL-6, IL-1 and TNF-alpha with the organum vasculation of the lamina terminalis may lead to the fever. Exogenous pyrogens may stimulate cytokine production or may act directly on the OVLT. Pathophysiology, in contrast, hyperthermia of heat illness or malignant hyperthermia is an unregulated rise of the body temperature caused by inability to eliminate the heat adequately or unregulated muscular activity. Physiologically, fever begins with the production of one or more pro-inflammatory cytokine in response to exogenous pyrogenic substance such as microorganisms or toxic agents or immunological mediators. IL-1, the first purified protein, as well as other cytokines, TNF, lymphotoxin, interferon, and IL-6 were documented to induce fever. The Society of Critical Care Medicine and the Infectious Disease Society of America issued a consensus statement recommending that core temperature of higher than 38.3 degrees centigrade or 101 degree Fahrenheit be considered as fever. In ICU, body temperature can be measured through a number of methods, including thermistor, intravascular, bladder, manometer, esophageal and rectal probes, in addition to infrared tympanic membrane and temporal artery thermometers. Etiology of fever in ICU, it may be infectious cause of fever, it may be non-infectious cause of fever, it may be hyperthermia syndrome. As we can see in this chart, there are non-infectious cause of fever. It includes inflammatory conditions, it includes vasculitis, it includes some other vascular conditions like DVT, pulmonary embolism, and dissecting aortic aneurysm, mesenteric ischemia, hemorrhage, and many other conditions like heat stroke, hypothermia, and even the neoplasms, lymphoma, renal cell carcinoma, hepatocellular carcinoma. So the is a grossly inflammatory condition, vascular condition, metabolic, neoplastic. So most of the non-infectious etiologies, and inflammation is the most common of them, and it causes inflammation, causes cytokine system and trigger the systemic inflammatory response syndrome. And this SIRS can occur in critically ill patient with large hematoma, including vasculitis. Fever may appear in the patient in whom stress of surgery unmasked adrenal insufficiency or following bilateral adrenal hemorrhage. Fever is also a cardinal manifestation of the delirium tremens among the patient with acute alcohol withdrawal, although it is necessary to exclude other complications of alcohol abuse, such as pneumonia and spontaneous bacterial peritonitis. Fever associated with seizures must be differentiated from underlying causes of seizure, like, for example, meningitis, encephalitis, brain abscess. Drug fever is also a disorder characteristic by febrile response coinciding temporarily with the administration of a drug in the absence of any underlying condition that can be reasonably for the fever. A key difference is that if we discontinue the offending drug, the fever automatically get subsided. Fever among the patient having malignancies, they have some patient having with malignancy might have pyrogenic cytokines production that may causes fever. And also hypothermia is an unregulated rise of the body temperature, a failure of thermoregulatory hemostasis. Malignant hypothermia, neuroleptic malignant syndrome, and serotonin syndrome are conditions that produces high temperature, resulting from hypothermia. This is not fever. Fever and atelectasis are common after surgery, and in the absence of infectious causative mechanism, atelectasis is commonly thought to be a cause of fever. Accurate and timely recognition of the non-infectious causes of fever can be can avoid unnecessary use of antibiotics and reducing risk of untoward reaction and side effects. Now, the infectious cause of fever in ICU. Infection common causes are UTI, including pyelonephritis, prostatitis, vascular devices induced, cellulitis, phlebitis, bacteremia, intra-arterial access site-induced bacteremia, respiratory pneumonia, it can be empyema, lung abscess, it can be any surgical wound related, maybe skin and soft tissue infection, gastrointestinal, and it's as per the organ involved, it can be the hepatitis, intra-abdominal abscess, prosthetic device infection, and other miscellaneous causes, including meningitis. Pneumonia and surgical site of infection are the most common infection type. Infections other than those associated with central catheter, urinary catheter, and ventilator account for the majority of the healthcare associated infections. Secondary bacteremia may originate from multiple sources. It can be lungs, it can be genitourinary, abdomen, skin, and soft tissue, and can develop as a consequence of vascular invasion via intravenous and intra-arterial line monitors. Temporary intravenous transvenous pacemaker and intra-aortic assisted device. Healthcare pneumonia, hospital-acquired pneumonia is the most common hospital-acquired infection in ICU and is mostly occur in a non-ventilated patient. And mechanical ventilation with the intubation causes further rise in the risk of pneumonia. And in intra-abdominal infection, peritonitis is the second leading cause after complicated pneumonia, is around 5.8 to 10% to all the patients. Abdominal infection represent the third most common cause of sepsis in ICU and present an important diagnostic and therapeutic challenges. Urinary tract infection is one of the common hospital-acquired infections. 7 to 8% of these infections are attributable to indwelling catheter. Partial or total obstruction or local complications, including intrarenal or perinephric abscesses, must be suspected in patient with bacteremic pyelonephritis if fever and bacteremia persist, in spite of optimal antibiotic therapy. And other appendicitis, cholecystitis, bowel perforation is also causing the fever with sepsis. Microorganism involved, including a spectrum of gram-negative and gram-positive bacteria, maybe with anaerobes and fungi. Hospital-associated infections are commonly with the it may causes multi-drug resistant pathogen-induced infection. Patient may have multiple comorbidities, be at high risk of treatment failure, may already be septic at the time of admission, or sometimes extensive use of antibiotics may cause Clostridium difficile colitis. And nosocomial sinusitis, nasogastric and tracheal tube, facial fracture, and nasal packing can cause nosocomial sinusitis. Diagnostic consideration for any patient having fever in ICU, we have to go with the first with the clinical we have to clinically, we have to look for any sign and symptoms of fever and underlying causes. And after the clinical, we have to look for the clinical as well as lab parameters. There are different parameters that can give us some information regarding the infections, including the WBC count, C-reactive protein, procalcitonin, and to more specific, goal directed, we need to send the cultures as soon as the patient is in ICU. We have to in very first hour of the ICU admission, we have to send the cultures, blood culture, urine culture, and we have to start the antibiotics. So the culture is very important. And so apart from basic diagnostic, clinicals, and as well as lab parameters, we need to send the cultures. We need to go for the imagings to exclude that organ specific or site specific uh, infections. And along with that, if we suspect any tropical fever, then we need to send all the tropical fever parameters. Treatment consideration, the most important is to aggressive resuscitation and adequate source control, appropriate antibiotic and organ support. Antibiotic, as soon as we have to send the culture within an hour, we have to start antibiotics. It should be empiric, depending on the clinical suspicion of source of infection. And so within first hour, we have to send cultures. We need to start antibiotics. We need to give bolus fluid, and the initiation of appropriate antimicrobial therapy is very important in effective management of sepsis and septic shock. Sometimes, in suspicion of invasive candidiasis, we may need to add empirical antifungals. And antimicrobial therapy should be evaluated uh, based on the safety profile and the type of infection. And negative culture in a patient who is only not improving yet stable on broad therapy indicate that antibiotic need to evaluate the antibiotics. The most common pathogens in ICU are gram-negative bacteria like Klebsiella, Escherichia coli, Pseudomonas and Acinetobacter, and gram-positive Staph aureus. In light of possible impairment of mechanical and immunological defense and presence of invasive lines, febrile ICU patients should be considered to be bacteremic primarily, unless proved otherwise. If the clinical suspicion that the fever is device-induced, we need to change the line. We need to change as soon as we need to remove the line, send the cultures from the periphery and one from the line. Then we need to remove the line. And along with the antibiotic, now we know that there are different types of antibiotic we have. We have hydrophilic antibiotic, including aminoglycoside, beta-lactam, glycopeptides, and most commonly affected by pathophysiologic changes observed. And lipophilic antibiotic like fluoroquinolone, macrolide, tigecycline, and infusamides. As I told, antimicrobial administration should be in the first hour. Dose interval of the antibiotics is as per the creatine clearance and half-life. Usually, we try to, in clinical scenario, beta-lactam optimization strategy often include the use of prolonged infusion to each dose interval as a continuous infusion for 24 hours. So this is the antibiotics. Depending on this table shows the presumptive antibiotic therapy in the ICU, depending on the possible source. Vascular line-associated bacteremia, endocarditis, bacteremia. So this in pneumonia, as we can see, in case of pneumonia for Staph aureus suspicion, so we can give gram-positive coverage of vancomycin mesory, and along with if resistant, then we have to go for the other antibiotics. In that way, this is the empiric antibiotic list we have to follow. I am not going into the details of each and every one. Initial therapy, as I have told, within first hour, I have to send the culture, give some fluids, start antibiotics, and we need to, if we are suspecting acute overwhelming infection of unknown uncertain source, then we have to start with both gram positive and gram negative coverage. with vancomycin as well as third generation or fourth generation cephalosporin and a fluoroquinolone to treat gram-negative bacilli. In non-immunocompromised host with a early onset VAP and no risk of resistant pathogen, monotherapy with narrow spectrum of non-pseudomonal third generation cephalosporin can be used. So, other situation, initial empiric treatment can be the broad spectrum beta-lactam antibiotic targeting Pseudomonas and or extended spectrum beta-lactam is producing Enterobacteriaceae, ceftazidime, cefepime, 5% azobactam, and non-beta-lactam anti-Pseudomonal aminoglycosides or fluoroquinolone. For patient having febrile neutropenia, anti-Pseudomonal penicillin and cephalosporin or carbapenem is recommended. Vancomycin is added for emergency management. Empiric treatment must be streamlined once we have the culture reports of the pathogen. In case of mixed bacterial infection, we have to use the combination therapy or including the extended spectrum beta-lactamase antibiotic with fluoroquinolone, and along with that, we may require anaerobic coverage by using clindamycin or metronidazole, and as an alternate regimen in ICU, we can step up to carbapenem. Fungal infections we may have in 5% of the patient in trauma, burn, abdominal surgery, and the patient who are on chronic parenteral nutrition or on chemotherapy. So those patients may require antifungal prophylaxis. Aspergillosis infection and mucormycosis caused by the members of mucorally order are emerging infection in ICU. And early recognition and treatment is very important to treat the patients. Multi-drug resistant organisms poses a huge challenge to us, and we have multi-drug resistant Pseudomonas aeruginosa, we have Escherichia coli, Klebsiella, pneumonia, and Acinetobacter, and they may have that Oxa variant, they may have Klebsiella producing carbapenemase variant. So the newer point, ceftazidime avibactam is a good choice to cover those KPC or Oxa producing organisms. So we have some additional concern regarding the OMP3 mutation. So we have to be due to loss of purine channels. In that way, that ceftazidime avibactam is a good combination. And Acinetobacter pneumoniae is a major hospital associated pathogen that can cause a huge spectrum of disease. Although there are several new beta-lactam lactamase inhibitor is there, but none of them are always foolproof. But ceftazidime avibactam is Enterobacteriaceae, and next is the vancomycin resistant enterococci. Is also a major source of morbidity and mortality, and we have options like linezolid, daptomycin, and tigecycline for the serious treatment of nosocomial infection caused by vancomycin resistant enterococci. Treatment of fever, with the exception of acute brain injury and hypothermic syndrome, disorder of temperature control with the practice of temperature control in the ICU remain controversial. Antipyrectic use in non-neurocritical ill patient with fever and suspected or confirmed infection does not affect the mortality, but effectively reduces the temperature. Antipyrectic relieve the discomfort and decrease the metabolic rate associated with fever. Early administration of acetaminophen to treat the fever due to probable infection did not affect the number of ICU days mortality. Now, after this hypothermia and fever, now I will discuss on hypothermia. Hypothermia occur when core body temperature is less than 35. Mild is 32 to 35, moderate 28 to 32, severe less than 28. And there is as per the Swiss staging system, stage 1 is clearly constant severing. Stage 2 impaired consciousness without severing. Stage 3 unconsciousness. Stage 4 non-breathing, and stage 5 is a death. Causes of hypothermia, the mechanisms due to increased heat loss, decreased thermogenesis and impaired thermogenesis. The causes are the aged and infant are there in high risk. Environmental factor, drowning, exposure, uh, maybe drug-induced alcohol, vasodilators, sedatives, sepsis-induced, CNS disorder like hypothalamic hypopituitarism, endocrine problem like hypothyroidism, adrenal insufficiency, hypothermia, trauma, burn and spinal cord injury, shock, skin disorder like psoriasis, and iatrogenic cold fluid administration during winter season, intraoperative therapy and therapeutic hypothermia, psychiatric may lead to exposure. Effects are in cardiovascular system, it causes bradycardia, decreased QN, it causes vasoconstriction. In the ECG, there will be a widening of QRS, prolonged PR, and QT, JOF, and the risk of ventricular fibrillation if temperature goes below 28, with an increasing blood viscosity and myocardial work. In respiratory, there is decreasing carbon dioxide production, decreased PaO2 and PCO2, percentage of carbon dioxide due to increased gas solubility, increased dead space, diaphragmatic fatigue, and metabolic acidosis. Ultimately, it causes pulmonary hypertension. In GI, it decreasing the hepatic metabolism and blood flow, decrease splanchnic circulation. In metabolic, it decreases the BMR, severing and left shift of oxyhemoglobin dissociation curve, and hyperglycemia and decreased drug metabolism. In CNS, neuroprotection is a fixed dilated pupil if less than 30 degrees centigrade. It may mimic the brain death. Hematology, increase bleeding time, PTAPTT, and increase the VT risk, decrease the platelet and WBC counts. In renal, it decreases the GFR and sometimes causes cold-induced diuresis. Management, we have to resuscitate the patient. So there are some modifications. So we need to increase the temperature. We will check the pulse, and because in hypothermia state, it will be difficult to assess the pulse. So and we will start the CPR, but if patient, if the temperature is until that temperature should be more than 30 degrees centigrade for the drugs to get work in a better way. Between 30 to 35, the dose interval of the ACLS drugs should be twice, double the dose interval. During normally during CPR, adrenaline every 3 to 5 minutes. But here we have to longer the doses. And for giving the shock, temperature should be more than 32 degree. Otherwise, there will be no effect of shock on cardiac arrhythmias. And we have to go for passive rewarming of the patient. We need to maintain the environment dry. We need to keep some warm blanket, peripheral active warming, chemical heat pad, radiant methods, and all. And a drop in the core body, sometimes please note, a drop in the core body temperature during rewarming may occur a consequences of peripheral vasodilatation and release of cold peripheral blood to the body core. It is not usually significant. So in that way, there are many other methods to treat the hypothermia. Then we can also go for thoracic lavage, and there are different methods through which mechanism we in this following process, following types or methods. Here in this slide, we can see the rate of increase in the body core temperature. Now the important topic is therapeutic hypothermia. Therapeutic hypothermia, at present this is called targeted temperature management. It is induced hypothermia successfully during cardiac surgery or sometimes during cardiac arrest scenario or traumatic brain injury. Practical uses, like we have discussed that during hypothermia we have the risk of bleeding, infection, arrhythmias, and shivering. Targeted temperature management, I will give some few of the points regarding the TTM. So current evidence that normothermia and actively avoiding fever more than 37.7 degrees centigrade has no significant difference in morbidity and mortality compared to therapeutic hypothermia of maintaining the body core temperature 33 or 36. However, there are some agencies like ESICM and the Australian and New Zealand Committee on Resuscitation continue to recommend therapeutic hypothermia of between 33 to 36 degrees centigrade for 24 hours for in-hospital cardiac arrest. So now the overview of therapeutic hypothermia, I will not go into the details. The mostly the population who are aged less than 18, pregnant, non-cardiac cause of arrest is not a case for targeted temperature management. So now here is the full details of therapeutic hypothermia. I will not go into the details of that. And in the evidence, so there are different evidence of targeted like HACA trial. It shows that 24 hours of cooling to 40 to between 32 to 34 degrees centigrade versus usual care demonstrate favorable neurological outcome. TTM trial didn't showed any benefit between the arms, and Hyperion trial, it shows significant improvement in the neurological outcome in the treating arm. Same TTM2 trial, it demonstrate no significant difference. So it means in some trial there is some benefit of the targeted temperature management, in some there is no benefit. And along with the hypothermia management, we need to manage the shivering through tire therapy of that. I will not go into the details. So you can see both hyperthermia and hypothermia is equally important in our ICU. Hyperthermia may be due to non-infectious cause, may be due to infectious cause, or it may be due to some dysregulated thermoregulatory mechanism of the body that may causes hyperthermia. So whatever the reason, we need to control the temperature. Although in non-neurological case, in non-neurological causes of hypothermia, so temperature control cannot give us the mortality benefit, but we have to control the temperature to decrease the metabolic demand. And we need to give antibiotic goal directed initially with the empiric, and later we need to give as per the culture reports, and need to start antibiotic as early as we can. And a common cause of hospital acquired infection is pneumonia, and mostly in hospital we get a mix of infection of multi-drug resistant organism. So we have to give antibiotic in a broad spectrum, both covering gram positive and gram negative. And if we suspect, we need to cover that oxa or carbapenemase producer with the ceftazidime, avibactam, and the newer generation antibiotics. Regarding hypothermia, as we can see, hypothermia is a tremendous multiple adverse effect on our body. Although sometimes we use for some benefit in case of traumatic brain injury, or after cardiac surgery, or in hospital cardiac arrest, but that need to be fully protocolized in a proper way of the TTM, targeted temperature management. One twist in hypothermia with CPR, we only can cardiovert if unless and until temperature beyond the 32 degrees centigrade. Otherwise, there is no response to the cardioversion or defibrillation. Thank you. So here is my brief presentation on temperature management in ICU. Now I open the floor for any queries. Then we will and I request our moderator, Dr. Dipankar Sarkar, please have your session now. Thank you.
Thank you, Dr. Mitra, for an excellent elaboration of the subject, the temperature in ICU. And by this time, you will get to know that both hypo and hyperthermia are the problem. Hyperthermia has got many causes. If you put it in a broad heading, it is infective and non-infective. So the biggest headache of the intensivist is the infective cause of fever, and we are talking that day in and day out. The non-infective causes of hyperthermia, that's very important, because when to stop antibiotic, that is another highlighting point in critical care, that non-infective cause of fever should not be treated. And in today's date, in some part of the country, the heat wave is going on, and probably heat stroke or heat hyperpyrexia is one of the most common non-infective cause of high rise of temperature. Present context, it has got some value. And as far as the hypothermia is concerned, the regulated temperature during cardiac resuscitation and the unresponsiveness of myocardium to defibrillation if the temperature stays below a certain level is the highlighting point. In our country, in certain places, we have got hypothermia. Probably in many places, we do not encounter hypothermia, but always remember, in critical care unit, make sure and keep the patient warm so that hypothermia does not develop. I think the question, there is no question in the chat. Oh, yes. There is one question in the chat box, which is by Dr. Sarkar. For patients who have cardiac arrest, we do TTM. Within what time we should start TTM? Is there any time factor? Now,
Yes.
Dr. Mitra, this is one question that you have to, because you have elaborated it in your slide, just reiterate the findings.
Yes. We have to start the targeted temperature management within 24 hours of in-hospital cardiac arrest, and we can maintain up to 72 hours. But the initiation should be within 24 hours.
So the highlighting point, what you have asked is that when to start within 24 hours at any point of time. The early you do this, the basic ideation of this targeted temperature therapy is that you minimize the organ dysfunction and keep the cerebral function intact as much as possible. So that is the hallmark, and rest of the thing, how long will you continue? It is 72 hours. I think the question has been answered clearly. And any other question right now? There is no question in the chat box. Okay. So if you can, Dr. Mitra, if you can tell one thing to the people, that many patients, like burn patients and electrocuted patients, you need to keep the temperature. That temperature control play an important part in these two type of patients. So if you can highlight the salient point, especially in burn patients.
Yes. In case of burn, or in that case, we have to avoid getting
The after effect of burn is hypothermia. So that's very important, because there is suppression of the bone marrow and the patient suddenly becomes leukopenic. So if you can highlight on that.
Yes.
Yeah.
In this slide, you all can see that the effect of hypothermia in the different organs and system of the body, and especially in burn patient, it may causes further risk of hypothermia from the exposed skin. And also there is the rising in the infections. There is a cardiovascular, respiratory, in every organ, in every system there might be a effect of hypothermia. Especially in case of kidney, there will be decrease in the GFR and alteration of the renal blood flow. And in the hematology, there is increased chance of coagulopathy in hematology consistent. In that way, in every system, we have the effects of hypothermia.
So,
and also We have one more questions in the chat box. TTM patient should be sedated or not? Need paralysis? Yes. During hypothermia, we need to sedate the patient, and if required, as because our main purpose to decrease the cerebral uh, oxygen demand and metabolism. So if we lower the body temperature, then we with the idea it may cause neuroprotection by decreasing the cerebral metabolic needs. So in that case, patient need to be sedated, and paralysis is not always essential. It depends on the patient to patient, but yes, the patient requires sedation. And if any patient ventilator asynchrony, then we have to also need to give some muscle paralyzing agent, but it is not advisable always.
So the question is, I think it's clear that you give sedation, but muscle relaxation to be given according to the situation and according to the clinical condition. And you have to, it cannot be a blanket prescription. It depends on the patient to patient.
Yes.
So I think we can wrap up the session if there is no question. So temperature management in critical care unit is very important, and Dr. Mitra has elaborately told about everything it takes and all the reference regarding it has been well highlighted. Thank you, Dr. Mitra, for an excellent presentation. I think you need a big hand, but it is a webinar, so that is something. It's our thanks that you take out your time and give that lecture. I think all the participants have been enriched by your well described elaboration. Thank you very much.
Thank you, sir. Thank you, Dr. Sarkar.